My name is Kundai Chinyenze. Today I'm going to talk to you about what we have in stock, reviewing the current status on products to address HIV prevention. Significant progress has been made in the reduction of new HIV infections. As of 2020, UNAIDS tells us that there were 1.5 million new infections. This was against a target of 500,000. Significantly more work needs to be done to be able to reach our goal in the coming years. We know that the HIV epidemic is diverse globally, with regional differences in incidence and the populations that are affected. We see that among female sex workers, men who have sex with men and transgender people, that they are disproportionately affected by HIV, sometimes facing up to 30 times higher risk of HIV acquisition than the general population. When you look at adolescents and we see the infections that are coming out of these populations, 6 out of 7 new infections in adolescents are actually among girls, much more significant than their male counterparts. Thankfully, we have an expanding HIV prevention toolbox that has come a long way since the years of the 3-pillared ABC: abstain, be faithful, and use condoms. Now we have a range of tools that are able to address various populations and can be used in various combinations to be tailor-made for the different populations. Whether you're looking at prevention of mother-to-child transmission, or you're looking at prevention HIV infection in people who inject drugs. Looking at voluntary medical male circumcision, this is one tool that is a one-time measure and offers lifelong protection. We have seen data that shows 60% reduction in heterosexual transmission of HIV from women to men. And as the goal that was set in 2016, that was looking at attaining 25 million additional circumcisions by 2020. What we have reached is 15 million by the year 2020. We continue to see challenges in the rollout of programs such as this. And one of the challenges that came out in the voluntary medical male circumcision programs is a challenge as related to reaching men at higher risk of HIV. And some of the reasons that were raised are around fear of pain, low risk perception, and low support from partners. And this does impact the ability of men to seek out some of these tools. Turning our attention to PrEP, this has been very topical over the past few years. Kate Segal reported at HIV R4P that there have been 1 million PrEP initiations in 2020. And this is very encouraging to see a rising trend in oral PrEP use. Unfortunately, this is only 30% of the target of 3 million that was set by UNAIDS for 2020. And whilst we see positive trends in places such as London and Europe in terms of uptake of PrEP, in sub-Saharan Africa, we continue to see low uptake in young and mobile populations, as well as female sex workers and women at risk. We are also learning and continuing to see that adherence to daily pill taking is a challenge for many individuals. For example, in a cohort in Kenya, when measuring by dried blood spots, it was noted that less than 15% of men who have sex with men who were reporting PrEP use had protective levels that were equivalent to greater than or equal to 4 tablets a week. When we're also looking at PrEP delivery, it is really critical to ensure that the models need to be well considered to support high uptake and persistence in the various populations. For example, community-based deliveries that really bring the PrEP as close as possible to the users are appearing to be more successful in supporting PrEP use and adherence, including the use of peer support models in either counseling or the delivery of PrEP. When you're looking at adherence, several factors have been reported in literature, including fear of stigmatization, the side effects of PrEP, and these continue to come up as reported across different populations. In this slide, We see data that's coming from different populations, whether it's men who have sex with men, female sex workers, adolescent, girls and young women across the world, and the challenges that they're experiencing in terms of uptake and adherence to PrEP. And we're continuing to learn how we can improve this HIV prevention tool going forward. So when looking at the next generation of PrEP options and how these can be informed by lessons learned, we have realized that we need products that are long-acting to be able to mitigate adherence challenges that continue to be reported. We need products that can support discreet use and that have improved side effect profiles and are able to support reproductive health needs of women. Additionally, PrEP needs to be delivered within a holistic intervention, acknowledging the other needs of the target population. And this is the way that we can maximize acceptability in these groups. The cost of goods is critical, and products need to be cost-effective and affordable for governments to be able to procure them for their citizens. And some of the issues that we are seeing, whether related to long-acting injectable cabotegravir or daily oral PrEP, there's a recognition that we need to have improvements in diagnostics to be able to address the HIV testing needs in the context of PrEP. When we're looking at the next generation of PrEP options that are coming down the pipeline, there's a range of exciting options, including microbicides, vaginal rings, the recently dapivirine ring that recently received a positive scientific review by the European Medicines Agency and recommendation by the WHO, and hopefully is being reviewed and will soon be available for women in sub-Saharan Africa. We also know that 3 monthly rings are under development, and this is an exciting platform in that it has the potential for multi-purpose use to include protection from contraception and sexually transmitted infection. We also saw exciting data coming through from the long-acting injectable cabotegravir that is administered every 2 months, and we saw data of high effectiveness in cis men, transgender women, and cis women in sub-Saharan Africa. Additionally, we hear of lenacapavir that's under development and will be able to be provided every 6 months. And even more encouragingly are implants that are being developed that can be administered and be used for up to 1 year at a given time. Also, our long-acting pills like islatravir that can be administered and have extended effect over 1 month. And we also have monoclonal antibodies, also known as broadly neutralizing antibodies. And again, the desired goal is to have long-acting bNAbs that are effective and can be administered every 3 to 6 months, for example, administered subcutaneously, and have the potential for lower toxicity compared to the ARV-based PrEP options. And of course, the cost of goods needs to be reviewed in the context of bNAbs. Finally, the development of a safe and effective HIV vaccine remains a critical component of our HIV prevention toolbox. In addition to all the tools that are currently available, I think it is critical for us to have an HIV vaccine that will help us be able to control and reach a sustainable end of this epidemic. When we're looking at the desired target product profile of the HIV vaccine, we're looking at a vaccine that would have long-lasting protection, if possible, bringing lifelong protection. Ideally, of course, it would be addressing the adherence challenges that have come up repeatedly when we are looking at other prevention tools, and really looking at a product that has potential to protect the widest range of populations that are at risk. Additionally, you'd want a vaccine that has few doses, that has a favorable cold chain to be able to be widely rolled out in low and middle income countries, and has cross-clade protection to be able to protect against the strains that are circulating globally. In conclusion, the HIV epidemic remains a significant global challenge. The HIV epidemic is very diverse on a global level, with regional differences in both vulnerable populations as well as incidence. And whilst we have a diverse HIV prevention toolbox, we continue to see challenges in rollout, uptake, and persistence. And we have learned some important lessons from existing prevention tools that must be applied to the development of future generation products. And as we're developing these products, we need to be informed by populations that are in need so that we ensure products that are appropriate for the context where the products will ultimately be used. In closing, I would like to acknowledge the broad range of stakeholders, researchers, organizations, and participants that take part in the development of in the continuing development of HIV prevention tools. And I would like to acknowledge the generous support that is provided by major donors that make the work that we do in IAVI possible. Thank you.